All right, good morning, everyone. My name is Carl Henson, and welcome to our webinar on novel coronavirus or COVID-19. This is available by Zoom, but also through the Facebook page of the Philippine College of Physicians and the YouTube channel of the Philippine College of Physicians. So I know in the poster it says only 100 attendees in the Zoom webinar, but since it's also available in other channels, then you can tune in through that as well. So I'd like to thank you for tuning into this special webinar. This is brought to you by the Philippine College of Physicians and the Philippine Society for Microbiology and Infectious Diseases. I'll be your moderator for today. For your questions, you can use Zoom or Facebook or YouTube, and you can type in your questions through there, and someone will be taking notes to give us your questions. This morning, I'd like to introduce our speaker. Let me just share my screen. All right. Our speaker for today is Dr. Jean Solante. He is a member of the Board of Regents of the Philippine College of Physicians since 2017. And he is affiliated with both San Lazaro and UERM. He's the chairman of the fellowship program of the Adult Infectious Disease and Tropical Medicine in San Lazaro, as well as a MS4. He's also the chair of the ID section in UERM, as well as an assistant professor, and he's a past president of our society in PSMID.
Good morning,
Dr. Solante, let's welcome Dr. Solante.
Okay, good morning, everyone. So we'll start with I'll also introduce Carl, sorry. So Carl here is one of the uprising young ID in our country. Currently, he's affiliated with the Medical City, director of the Hospital Infection Control and Epidemiology Center, training officer of the newly established Infectious Disease Fellowship Program of the Medical City, and as also the assistant training officer of the Internal Medicine Residency Program, regular consultant, section of ID, and he also holds position as clinical associate professor, Division of Infectious Diseases in UP College of Medicine, and currently the assistant treasurer and member of the board of councils of the Philippine Society for Microbiology and Infectious Diseases. Good morning, Carl.
Morning, sir. All right, let's start with our first question. So what is COVID-19 and how does it differ from other coronaviruses? So Dr. Solante, why don't you start?
Okay, so coronaviruses are RNA viruses, and these are already present in our in the environment for so long. And there are four groups of these: the alpha, the beta, and then you have the delta and the gamma. But this is one of the most common causes of the upper respiratory tract infections. In fact, it's between like 10 to 50% of the common colds are also caused by coronavirus, especially affecting mostly the pediatric population. But what makes this more popular was the emergence of two serogroup of this coronavirus, which has caused outbreak and large proportion of mortality in 2002, which is the SARS coronavirus, and then in 2012, the Middle East respiratory syndrome coronaviruses. And if you look at the way how this coronaviruses causes from an animal, because most of if you look at the phylogenetic tree of the coronaviruses, it is in all types of animals, okay, from birds to snakes to pangolins, including bats. But I think in that particular aspect, it's really common among bats. And both the SARS and the MERS-CoV, okay, the primary host then was identified as the bats. But there was also this intermediate host. For the SARS-CoV, it was the civet cat, and then the MERS-CoV, the dromedary camels, which was the host, or which were the conduit that these viruses transferred to the human being. Okay, So it takes a lot of something like a mutation or changes before this particular virus can jump from an animal species to a human species. Okay? And I think they call this spillover event. Okay? If you look at how the current concept now that the novel coronavirus affected a human being, they theorize that this originally came from a particular bat that also carries the SARS coronavirus. And they're still thinking which intermediate host that this bat uh, uh, transmitted the virus. There are theories that the genomic sequence of the pangolin coronavirus is the same as that with the human coronavirus. And there are also papers that will tell you that it has the same genomic sequence with a snake and that of a civet cat. No? But again, there's no established, we haven't established that yet. No? And there's also a possible theory that from the bat, it goes directly to human beings. Now, it was first documented among those patients who were admitted because of pneumonia, and the commonality among those patients that developed pneumonia in China, particularly in Wuhan seafood market, and they theorized that any animal in that particular market was the potential reservoir of the virus that infected the human being. So just like to show you here the different or the other emerging viruses that we've had in the past. And if you look at most of this, we can always emphasize the casualty because that's the most important. And comparison with SARS, the case fatality rate is like 9.6. The MERS-CoV is like 34.4%. But at the current rate, this SARS-CoV-2 is affecting human beings. We really have a very low mortality rate of around 2.2 to 2.5%. Okay, so now I'll ask you, Carl, also, no? Since we know that this virus is already in the environment, but what did really trigger the emergence of this novel coronavirus in the environment that triggers the current outbreak?
Okay. First of all, before I answer that, sir, I was told to inform everyone who has joined us that the PCP will give one CPD unit automatically for anyone for everyone who has joined us this morning. So one CPD unit for all of you. All right, so let me begin with sort of a brief history of what has happened. No? On December 31st, there was the first report of a pneumonia cluster in Wuhan, China. So this was the parang CDC of China was informed, the Health Commission. And by January 1, they had identified that the Huanan South China seafood market was a common denominator among the cases. So they closed that down on January 1st. By January 5th, the municipal committee announced that the cases among the patients that they were taking care of, they had ruled out flu, SARS, and MERS. No, and they still didn't know what the cause was of the pneumonia. In January 8th, the Chinese version of the CDC announced that they had identified a novel coronavirus that was isolated from patients with pneumonia, those who were in Wuhan. About 15 plus positive cases were confirmed. And then they isolated the first genome around January 10, and this was also around the same time where the first patient with this pneumonia died. And then on January 11th, there was 5 additional genomic sequences that they found as well. On January 13, Thailand reported its first confirmed case. By January 15, there was a second fatality. And then on January 16, so very rapid turn of events. On January 16, Japan confirmed 1 case. And then on January 17, a second traveler in Thailand. So by this time, I think we were all really very worried now that there was something going on. There's something that could potentially affect other countries. No? January 18 to 19, they expanded testing, confirmed cases in Beijing and Shenzhen. And then January 20th, they found the virus in healthcare workers who were taking care of these patients. By January 23, a total of 655 cases and 18 deaths were reported in China. So at this time, parang medyo konti pa yung cases, and then soon after this, it really rapidly grew in number. No? By January 30, the WHO declared that this was a public health emergency of international concern. And so far, since the concept of PHEIC began, there had been 6 declared by the WHO in the last 10 years. No? The 2009 flu pandemic, and then polio in 2014, 2 Ebola virus outbreaks, and a Zika virus outbreak in 2016. So how does the WHO view the current outbreak? They read it as a very high risk for spread in China, and in the rest of the globe, high risk of further spread. Okay. So these are the latest numbers. I'm sure that when you view this video tomorrow or in the next couple of days, you'll see, or you will note different numbers. But as of yesterday, the WHO has reported 71,429 laboratory confirmed cases, 2,100 of which are new. In China, they have 70,635 new cases to date. About 2,051 are new. And you will note that globally, China has the 99% of these cases. 1,777 of the cases have died. Outside of China, there are 794 laboratory confirmed cases in 25 countries, with 3 deaths, 1 from the Philippines, 1 from France, and 1 from Japan, with a mortality rate of about 2.5%. And this is the map that shows you the spread of the virus globally. No? So you can see a large concentration of the red dots in the People's Republic of China. This is just a list of the countries that have been affected, that have reported confirmed cases. And you can see that not including the ship in Japan, no, most of the cases are found in Singapore, and they already have reported local transmission in that country, followed by Japan. No? But the most recent one that we see in the news was the cruise ship that was docked in Japan, no? About 454 cases, 99 of them were reported new. This is the epidemic curve. I just want you to really look at just the colors. No? The maroon bars are those people who have some direct connection to Hubei province, and they really comprise most of the people among the 210 cases found outside of China. But then after around January 21, you find a little more of the pink bars, where so these are the people who have no travel history. So this indicates local transmission in the places where they had the confirmed cases. So, Dr. Solante, who are the patients at risk? Can you tell us more about the mode of transmission, the common clinical manifestations, treatment, and prevention?
Okay. So, it's very important for us to really appreciate, since this is an outbreak, one of the aspects that we have to emphasize is how can you acquire the virus, okay? So based on current data, you can only acquire it through close contact, and it can be through droplet transmission or a direct contact or an aerosol transmission. And most of the persons that can acquire this infection are usually those persons also who are in close contact with the known or highly suspect patients with novel coronavirus. That's why if you look at the aspect of risk of acquiring the infection, then you always have to look into number one, these are the healthcare workers who are taking care of the patients or who are travelers or who are in Wuhan, where the epicenter of the continuous human-to-human transmission are currently occurring. Okay? And if we are going to apply that in our local setting, and I think that's just but proper that we have a very good containment procedure now that we all screen individuals, especially those with symptoms who had direct travel coming from China, and not only in Wuhan. So this is just one way of showing you that how can the virus be transmitted through aerosol transmission. Okay? And there are high-risk procedures in the hospital. If you're taking care of a patient with highly suspicious of the novel coronavirus, once you are taking care of this patient, you have to really be complete with your personal protective equipment. And this is where you have to wear the face shield, the N95 mask, and the gown and gloves to be protected against the exposure coming from the source patient. Now, what about transmissibility? Okay, they have theorized and even identified that the cellular receptor that was identified during the SARS-CoV in 2002 was the same receptor that was by which the virus can bind in the human being. Okay, and these receptors are usually found in the lower respiratory tract. Okay, so what is the implication then? Meaning, if you have a patient with the infection, the higher probability that you can acquire the infection are those from patients who really have symptoms. Now, I would say, regardless of the severity, whether it's mild, moderate, or severe, we have now lots of data that anybody who had symptoms, especially respiratory symptoms, can transmit the infections. Those with lower respiratory tract disease, like coughing over that of a patient with just a sore throat, higher risk also of transmitting the infection. And there are also by means of droplets and contact. And if you have heard in some of the news or some of the articles, they're now looking at what is the possibility that there is an airborne transmission. And I think this has stemmed from two articles that was published by Chinese doctors that airborne transmission was possible, and it was one of the other aspect route of transmission occurring in Wuhan. And I think the other data was with a Japanese doctor who was taking care of those person quarantined in the cruise ship in which acquired the infection despite wearing the usual face mask, but not the N95 mask. Okay. Now, the transmissibility efficiency can also be computed through the use of the reproductive number. So, meaning this is the number of a particular person and its ability to infect other person. So they currently, based on computation, a single index patient can transmit the infection to at least 2 or 3 other person. Okay, and I think this really drives the sustained human-to-human transmission, which is responsible for the enormous increase in the number of cases reported in China on a day-to-day basis. Okay, so that's why the implication here is really on how to control the transmission. You need good laboratory to isolate the virus and isolate the patient also to prevent further transmission from that symptomatic case. So if we go through again, who are the people at risk? I have mentioned this one, those in close contact with animals, or those family members or healthcare workers in contact with the patient. But I have here collated first some articles coming from China who reported their cases, and these are published in Lancet and JAMA. Now, age. Most common age affected are the 45, 50, in fact, 50 years and above, no? And mostly are males. So someone asked me, why is this so? Is this predisposition of the virus to affect this population? My answer to that is that probably these are the individuals who goes to the market, okay, and then they were really directly exposed, repeated exposure, and causes this group of initial patients to be infected. Because if you look at all across this data, there is really more than 50% of these patients who developed the symptom had exposure in the Huanan market. But what makes this interesting is that if you look at the study of Huan, okay, 29% of those who develop the symptoms are healthcare workers. So the other risk group here are those really the healthcare workers who are taking care of patients positive for the novel coronavirus. Most common symptoms still fever, cough, and you have fever, cough, and difficulty of breathing. Now, I would like to point out here some of the peculiarities of some of their findings. Like, for example, one paper, this group of Huang et al. Mentioned that in 69% of their patients, only complaint of fatigue, aside from fever and cough. And then in another data, okay, this one, who the fourth column, which was patients that were positive for the novel coronavirus outside China, in fact, showed symptoms of very mild symptoms, and yet they have the virus, like upper airway congestion, muscle ache, and then cough. And in fact, like 40% only have cough, and look at the days of cough, like 1 to 2 days, no? So short duration of cough. So meaning it's quite difficult to really ascertain which among these patients has higher risk of transmission. But if you look at this, fever, cough, and dyspnea is the most common symptom among these patients. Now, we go to the other important aspect of those who died. And it's true that just like in any infection, comorbidities will really determine the outcome. And based on these studies, there are like 30 to 50% of those who had the moderate to severe clinical manifestation had comorbidities, and it ranged from cardiovascular, from diabetes to COPD to chronic kidney disease and chronic liver disease. Now, what is the most common lab findings? All papers will tell you we did not find, or we rarely find, leukocytosis. It's always either a normal leukocyte or a decrease in the number of the WBC. And again, a large percentage have decrease in the lymphocyte count. Now, why I did put here procalcitonin, because if you look at the value of procalcitonin in differentiating viral from bacterial, I think this is one study that can really validate that most of those patients in which they did procalcitonin, among this in this study, most of the procalcitonin is not significantly elevated. Now, common complications for those who died or higher risk of mortality, once you have acute respiratory distress, then that's really comes with a higher rate of mortality. Okay? So these are just a summary of the clinical outcome. Now, we'll proceed with this question, Carl.
So, sir, we received some questions in the Q&A a group chat window, and I just want to bring it up because I don't think we will cover it in the subsequent slides.
Okay.
So, Picasso Law Office is asking, so what are the symptoms which you have already talked about? So, fever, cough, shortness of breath, no, sometimes very fatigue. And then, should we measure the temperature of every individual who enters our office premises? And then they have a follow-up question about what practices can be implemented at the office to be able to keep ourselves protected from the virus.
Okay, so I think we have to look at it in the perspective that if your office is what, are you accepting travelers or foreigners, something like that? No? Because if it's just local visitors, then I don't see the need that you really have to implement that particular measure.
Right.
Since anyway you're asking the temperature, so 38 and above is the cutoff for patients that whom you will screen for fever. Now, that would be a very good entry to screen patients, the presence of fever, because most studies, patients with this infection will always present with fever. Okay? But I don't highly recommend implementing a screening procedure if you are in an office. Okay, the current procedure now in this screening procedure is mainly towards the healthcare setting, like hospitals. Okay, so you want to really strictly implement that because you want also to screen who are those coming in the hospital that are higher risk of being exposed and having the virus, and separating them from those who were not exposed and have the same clinical manifestations.
All right. And then I'd also like to add, so you mentioned, sir, that we really are emphasizing symptoms plus travel history. Symptoms plus travel history. And then you also talked about if they want to screen a temperature, it's 38 degrees. I was a little distracted, but did we mention hand hygiene also, sir?
Yeah, that I think that's routine for us, and I think we have emphasized that it's more important than wearing a face mask. No? And in fact, we discourage wearing a face mask in the public. Okay, the concept of wearing a face mask is like the mask that we're using now is to protect the environment from your secretions. It's not you being protected against that infection.
Yes, sir. Also, they're asking about routine for cleaning their office. I think if there's really no one who's sick in the office, routine cleaning. I want to mention that in the hospital, we're using bleach. That's 1 part bleach, 99 parts water. But that's really healthcare setting. And the only thing that we changed in Medical City was really to just wipe high touch surfaces more frequently than usual. There's a question on whether patients who are confirmed and are PUI need to be under negative pressure.
Okay, so ideally, if you are in an ideal setting and you have a patient that is really confirmed for the novel coronavirus, then the ideal setup there, they should be in the negative pressure. But that's not a strict recommendation because only like less than 10% probably of our healthcare facilities have negative pressure.
Yes,
Okay?
sir.
So what do we do if you don't have a negative pressure? Okay, you can create an isolation room. Okay, and in fact, a well-ventilated isolation room can be adequate. Okay, as long as you will not be doing procedures like encourage the aerosolization of the virus, like intubation or doing nebulization, then that would be okay. But the other aspect there is you put the patient in an isolation room, you give him the face mask, and while the patient will be taken care of the healthcare worker, then this is not compromised. The healthcare worker should be in full PPE, both confirmed, including those whom we suspect PUI until the laboratory test result will come in that the patient is negative.
Yes, sir.
How about you, Carl?
That's what we also do in Medical City. We have reserved some isolation rooms. Some of them are not the conventional negative pressure rooms, but we have sort of cohorted them. The
Like
healthcare
like
workers.
one floor and then individual room.
Yes, sir. So single private rooms. No? The healthcare workers are wearing the recommended personal protective equipment. Just so we're really talking to doctors, di ba? So for those who are into preparations for your hospital, in the commodity package released by the WHO, the recommended PPE for this disease is basically an eye shield or goggles, and then an N95 mask, gloves, single, you don't need to double it, clean, doesn't need to be sterile, and then a gown. The gown, ang recommendation is for it to be impermeable. So when I looked, I had to do a little bit of reading on this, but by definition, they mean impermeable when it's AAMI 3 gowns or 4. So if you can get a hold of those supplies and put them in your hospital, then that would be great preparation for taking care of PUIs. Okay. So let's go back to the question, sir.
Yeah. So we'll now proceed with the fourth question. No? I think this is for Carl. So what do you think is the current preparedness plan in the country appropriate? And the fact that we still don't have local transmission, are we happy with this? Are we contented with this? Or we still have to move up one level higher in order to maintain that absence of local transmission?
Okay. So in PSMID, really, we have received some questions about do we include Singapore, do we include Japan, or but let me talk first about what the Department of Health, what the government has done so far. No, so this is a summary of the cases of persons under investigation or patients under investigation since as of yesterday, no, February 17. And we have had 3 cases since the beginning of the outbreak. So we have had no new case for at least 14 days already. And that's very, very important. Cases tested that were negative, 453. Ang currently admitted na patients under investigation is 171 with no confirmed cases as of this time. And so far, since we started testing, there have been 453 patients that have tested negative with only 22 with pending results. No, and these 171 PUIs are spread out across the country with a bulk in the National Capital Region, 104 cases, and then followed by Calabarzon at 21 cases. They created an interagency task force for the management of emerging infectious diseases. And a member of this is PSMID, and I believe there was representation from PCP as well, and PIDSP, tapos some of the other departments that are involved. They met with President Duterte on February 3, and basically they reviewed the decision tool. So this was a decision tool that was released by the DOH, by the Bureau of Quarantine, on actually medyo hindi sila nagpalit kasi ng date but this version was released on February 2nd. So for the doctors who have been tracking the decision tool, please note that there have been several versions of the tool that were dated January 30. But the most recent one was released on February 2. This is the version that was accompanied by the letter that I will show you later, no? So, bakit ganito yung version ng Bureau of Quarantine? Because this is released and this is to be used from the perspective of someone who is in the airport, a Bureau of Quarantine personnel looking at patients coming in, no? So they will always start with fever. They will look at fever and then they will ask about respiratory infections and then travel history kasi by then alam na nila kung saan ang galing, no? And then they classify whether a patient is a PUI or a PUM. Under PUM, so you will know the version, which version you're looking at or you're holding by looking at the PUM kasi there were several changes. And the February 2 version contains, yung pinakahuling line is negative, 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 positive. Okay, so no fever, no respiratory infection, no travel history with a history of exposure. So this is the version, the latest version that was released by the DOH, and it has not been updated yet. For clinicians, the PSMID created an algorithm, no, and you might have also been following our version. And actually, I've been instructed also to clarify one area here under healthcare worker. We have a separate guideline for that. So suffice to say that the algorithm and the way we triage patients really is in flux. And for those of you who have been really following along yung changes, Taiwan has been an in and out thing. No? There has been a question, do we include it or not? But our latest directive from the DOH says that in terms of exposure, high-risk exposure includes travel from mainland China, including Hong Kong, Macau, and Taiwan. And then when you look at close contact, no? So there has to be close contact with a confirmed case. There naka-specify dyan yung how near you are to the confirmed case or whether you're in the same room and you're not wearing appropriate PPEs. There can also be direct contact with an infectious secretion of a confirmed case while not wearing appropriate PPEs. Now, like I said, um, healthcare workers, this part here, we might revise. We will take a look at it again later. There is a separate guideline for healthcare worker protection. No? After you look at, so from the clinician perspective, we start with travel or exposure history because that is the most efficient way to do it in your hospitals. In the hospitals, there will be people coming in for community-acquired pneumonia, for TB, who will present with fever. So we do not think that it's appropriate for you to start with fever in your triage guidelines. So PSMID recommends exposure first, and then once you obtain an exposure history, you look at symptoms. Fever more than or equal to 38 degrees Celsius, or cough or other respiratory symptoms. Dr. Solante has already told you that majority, more than 90% of patients will present with fever and or cough. There's a question here about whether we should include fatigue, but then we are really only looking at triage guidelines. So the most discriminating symptoms we will include. It is up to the clinician, the clinical judgment of the clinician to take a look at other symptoms. No? So if the patient fits the criteria for exposure and symptoms, then you take a look at time. No? So did the symptoms occur within 14 days of exposure? And if check yung tatlo na yon, then we call that patient a patient under investigation, and the patient needs to be admitted to the hospital. That is the DOH recommendation. No? And then the hospital should collect a nasopharyngeal swab and an oropharyngeal swab. The NPS and the OPS collected using different swabs but placed in the same viral transport media, same tube, and then coordinated with RESU for transport or sending to the RITM. After nun, you manage the patient accordingly. You know? So kung very symptomatic and very unstable, you admit to the ICU and then have your healthcare workers wear appropriate PPEs. But also, there are some, especially in private facilities, that there are some patients who refuse to be admitted. PSMID really does not have a very clear answer on this. The DOH says admit. For private institutions, you can try to transfer them to a government facility if the concern is cost. But definitely, RESU needs to be involved in the decision making and the disposition of these patients. Now, for patients who have travel history and do not have symptoms, they are classified as patients under monitoring. Patients under monitoring or persons under monitoring need to be, RESU also needs to be informed, and they also need a case information form because they also need to be tracked. You do not need to do a swab, and you send these patients home with advice. They have to be informed that they should be under strict home quarantine. Walang gala sa labas. No? So the PSMID has created a guideline for triaging and screening and how to manage patients under home monitoring, and we are going to release that very soon as well. So, all right. So these are DOH health advisories that would be good to follow. No, always practice hand hygiene. So you can use soap and water, and if it's not available, you can use an alcohol-based hand sanitizer. The alcohol has to be 70%, a 60 to 70% component of the product. No? Observe proper cough etiquette. So maintain this distance from sick people. And if you are going to cough or sneeze, you use a tissue or the crook of your elbow, no? What PCCP calls cough dab. And then avoid crowds and close contact with people manifesting with flu-like symptoms. But the better way to say this is if you are sick, if you have respiratory symptoms, you just avoid crowds. No, you stay at home. And then maintain 1 meter distance from people manifesting flu-like symptoms. Avoid touching your nose and your mouth because the virus is most effectively transmitted that way. Use a face mask if you have cough and colds or if you're a healthcare worker dealing with patients with respiratory illnesses. This is the letter that I was talking to you about that accompanies the most recent decision tool. So look for this letter. This is page 1 of that letter. And then on page 3, I think, is the decision tool. Now, it's dated February 2, and this is the memo reiterating the management of DOH hospitals of 2019 nCoV patients under investigation and request for recommended quarantine facilities within each region. Um, earlier there was a question of do private hospitals need to admit patients under investigation? PhilHealth says yes. All level 2 and level 3 hospitals are expected to have the capacity to take care of these patients. They all should have negative pressure isolation rooms. So they are also expected to have to take care of these patients in their own communities. No? And then there's also an RITM advisory for clinicians, dated February 2 as well. The important thing that you need to remember here is the testing algorithm. So for patients under investigation who get a swab, no, that's the first nCoV test. If it is negative, there is no need to repeat after the first swab. If it is negative, the patient is symptomatic, the test is negative, there's no need to repeat at this time. But if the test is positive, you basically need 2 negative tests that are spaced 48 hours apart. So if we're just going through the algorithm, so first negative test, positive, so you maintain in an isolation room with necessary precautions, and then you repeat the test 48 hours later. If the test is negative, you need another repeat, no, a second negative. If the test is positive, you keep repeating every 48 hours until you get a negative result. And then these are and we also need, so I know that as doctors, we are so focused on our own communities, no, and our own hospitals. But I think it's also important for us to really see the bigger picture. What is the WHO's strategic objective here? So they want to limit human-to-human transmission, including secondary infections among close contacts and healthcare workers, preventing transmission amplification events, and further international spread from China. So they also want to, the objective is to identify, isolate, and care for patients early. So early identification so that you can isolate them. And that is so we're in a containment mode. So that's the reason for the need to admit all symptomatic patients in the hospital. We want to identify and reduce transmission from animal sources, address crucial unknowns including regarding clinical severity, extent of transmission and infection, treatment options, and accelerate the development of diagnostics, therapeutics, and vaccines. Communicate critical risk and event information to all communities and counter misinformation. This is very, very rampant these days. So if you're not sure of what you're reading, it's not well referenced, please do not share it. And then minimize social and economic impact through multi-sectoral partnerships. So that's the WHO strategic objective. And then, sir, our last question before we go to some of the Q&A questions. What do you think are important learnings that we can take away from this outbreak to prepare for the next one?
Yeah. So I think if you look at the timeline of emerging viruses, okay, we have SARS, we have the H5N1, H1N1. Like a third world country like us, we have learned something, but we were not able to make it like a template that we will be using year in and year out. I hope you understand that. No? Meaning, not to offend our government, not to offend our healthcare setting, we have all of this in a policy form, in a paper form. But you ask yourself, did we realize and conceptualize that this policy has been realized in the healthcare setting? Like, for example, establishing a healthcare facility complete with an isolation room and a negative pressure room. Okay? And it's been so long that we always involve the healthcare facility to be the center of the management of this patient. And it's high time that although the government has realized now the importance of establishing these facilities, and that's why, as part of the health facility development plan of the Philippines through the Department of Health, the government is now conceptualizing and has identified strategic healthcare centers, no, in the government that will take care of these patients, not just relying on RITM and San Lazaro Hospital. And we will extend this facility not only for government, but also for the private hospitals. Okay? That's one. That's one of the preparedness plan. Number two, I think what we learned here is that how to convey important message in terms of public health prevention of transmission. Okay? And I think we didn't lack that way of dissemination because we have a lot of social media, the Facebook, and then we have the Philippine different medical societies, and of course the government. No? So the collaboration between the government and the private is really crucial because the government will take care of the higher and the overall preparedness plan, but the nitty-gritty of discharging this plan is really coming from the different healthcare society, okay, or the medical society, and even the healthcare facility. So those are just two of the things that probably we have to learn from this outbreak. How about you, Carl?
Well, look, so I come from a private institution perspective, and before the outbreak, we really had things in place, no, or at least like the skeleton in place. And one of the things that I really learned throughout all this was the system that we have in place. It needs to be stressed, meaning we can't just rely on what's on a piece of paper, and we need to do drills, etc., because we never really know what will happen once it's there. So right now, this outbreak has allowed us to identify gaps in our system and to strengthen those gaps. For the healthcare workers who are into infection control out there, your administrators will be very receptive to your suggestions and need for capex materials. No, if you want them to purchase isolation rooms and beds, I guess now is really the time to take advantage of this because it is really needed, and it is this time that we need to take to show them the importance of being prepared. We cannot just prepare and do construction in our hospital pag meron ng outbreak somewhere else in the world. So that's my take from all this, at least the biggest one. So, sir, let me just go through some questions from the Q&A chat group. The WHO announced that there will be a vaccine soon. To whom should it be given, and how about the efficacy of this vaccine? Do you want to? Well, the virus was sequenced in a matter of weeks, no? So it's really not very surprising that they are now saying that there might be a vaccine soon. I know that the NIH in the US has already talked about working on a vaccine. Pero syempre, this being a vaccine, it has to be given to those who are not sick and are not at risk. You know, they're not PUIs, definitely. Pero I think we also need to prioritize those who are not sick and are uninfected in the epicenter of the outbreak, which is in Hubei province. and then it should like spread outward into the rest of the world, depending on the supply of the vaccine. Um, Another question, sir. How about patients with symptoms from Chinatown only? Um,
Yeah, I think we have to really be cautious about that, no? Because I think in some countries there is now what we call the xenophobia. Anybody that looks like Chinese, you can be labeled as a probable carrier of the virus. No? So that's wrong, no? Because it entails as mentioned by Carl, you always have to look into the travel history, the presence of symptoms, and the presence of exposure. So we should not generalize anybody that is Chinese looking or coming from from Chinatown. No? So that's not a good way of looking at it.
I guess this question also relates to it. Anonymous attendee is asking, I had an employee assessed by a physician as rule out COVID PUI just because the patient worked in a POGO. The patient had fever and cough but no travel history. Is this a proper assessment? At this time, sir, we have no documented local transmission.
Yes. Because when you look at the POGO, okay, these are local. They have been here already for the past since December. And when you look at the travel ban advisory, it's really there are no more Chinese coming in the country, and there are also no more Filipino going out to China. So that alone is a big factor in the containment procedure.
There's a question here, how long should POMs be quarantined at home? It's in the PSMID algorithm. POMs have to be at home for 14 days because that's the incubation period of the virus. So they should stay at home for 14 days.
I think the Department of Health has emphasized the word monitored quarantine, meaning if you are quarantined at home, then you have to also follow some instructions like you cannot go out. Okay, you can stay in a particular room and less of the exposure to other members of the family. And as much as possible, if you can wear a mask, even if you are asymptomatic, then that would be better. And then I think there is now a local government participation in terms of monitoring this quarantined PUMs. No? So there is the barangay level that will monitor this individual twice a day for the temperature and the presence of respiratory symptoms.
Yes. So we answered that already. Dr. Kenneth Koo, CPM chair.
Yeah, Kenneth. Hi, Kenneth.
Yeah. So he's asking, do we need to take a very good history from our Filipino kababayans where they are coming from? Because we just got a couple, a Belgian and a Filipina who apparently came from Vietnam but had a business in Wuhan. So parang mga stopovers. So yes.
Yeah, that's a good point, no, Kenneth, because since we are now in the containment stage, although the Department of Health only mentioned some countries where the risk is very high because of the efficiency of the numbers or the transmission and the high numbers of daily cases, but again, it does not exempt other countries. Okay, it's better to be OA or what they call this one step ahead of the situation in order to really prevent the transmission. If anybody that is coming from abroad, you have to extract what country before the arrival, what countries did he had a stopover or did he travel, and I think that is pertinent in the that should be part of the history.
Yes. There's a question here about who is allowed to take NPS and or OPS from PUIs? Is it only the medtech? I guess it really is institution specific. In our hospital, in the medical city, it's the resident who is attending to the patient who will take the swabs. And then the tube is collected by the medical technologists. It might be different in other centers. No? How is it done in San Lazaro?
I think, yes, it's being done by our fellow. But if you review our competency in IM, I think that's part is specimen collection. And they have to be trained also. No? Part of that is training how to get the NPS or the OPS. That doesn't exempt them because that's their duty, no? Doctors.
Yeah. All right. And then lastly, sir, and do we need? All right. So there's a question here about, do we need to quarantine employees who visited Europe? At this time, the Department of Health is only recommending quarantine for patients who are coming from China, including Hong Kong, Taiwan, and Macau. Other than that, there is no recommendation to quarantine anyone else. Okay, so whether from Europe, from Japan, from Singapore, etc., it's really only China. Lastly, sir, I think this is a good question to end this session. After recovery, will this result in immunity?
Okay. So if you look at influenza, if you look at MERS-CoV, those patients who recovered, there's no such thing as immunity after the infection. These are infections that patients will not develop what we call a neutralizing antibody. Unlike in dengue, where you will be infected, the higher is the risk that you'll be protected against that serotype. But for these respiratory viruses, it's not. With additional exposure or with repeated exposure, then you can get the infection again.
Okay. So we have several other questions, but unfortunately, we have to end this webinar,
Yeah,
sir.
thank you.
We were informed by our computer people here that about 99 were in Zoom and about 58 were watching this from YouTube. But it's also important to remember that this session has been recorded and can be viewed in our YouTube, in the Philippine College of Physicians YouTube channel.
Yeah. Before we'll end, I would like to thank also the one who really conceptualized this, Dr. Debbie Ona and Dr. Mario Panaligan. So they're the ones who really envisioned this one, and we highly appreciate this type of interaction, putting in correct information not only to our members but also to the whole medical community.
Agree, sir. I think it was a very productive morning. We learned a lot, and thank you. Thank you. And we thank you all for tuning in. Have a good rest of your morning.